Sanjay Gupta, welcome back to That Said.
I am delighted to be here. I really enjoy our conversations, and I got to say, you're one of the guys who actually reads the books ahead of time, so the conversations are even better. I
Yeah,
appreciate that, Michael. Thank you.
thank you. I read, and I take notes, and I actually take notes not simply for the purpose of our conversation, but I actually refer back to them in my own health conditions, both with Keep Sharp and with the book that we're going to discuss. It doesn't have to hurt. Your smart guide to a pain-free life. So great stuff.
Thank you. I appreciate it, and the idea that it could, somehow help you in your current life. That's why you write these books. So
Ex-
that's great to hear.
exactly right. They're what I love about these books is that they're, as we'll discuss, they're substantive. Like, here's what we're talking about, and then part two, and here's what you can do about it. And sort of that's how you have this one structured too. What is pain? And then what can we do about it? So
Right.
why don't we start just a little bit of how did you choose this topic on chronic pain, essentially?
I've been thinking about pain for a long time, and I had shied away from it in the past because pain is really the most mysterious human sensation that we collectively experience. We all kind of know pain, we know that word, and yet how we define it varies considerably person to person. It even varies considerably within that same person day to day. What might hurt on a Tuesday may not hurt as much on a Wednesday. And initially, it felt very hard to sort of wrap my head around that for a book. Um, but I think, as a physician who treats a lot of patients in pain, and then as a journalist who spent a lot of time visiting with patients who are in pain, dealing with chronic pain, visiting pain clinics, talking to researchers all over the world, I realized two things. One is that it was an important topic and there was a way to contextualize it for people in a way that was meaningful. But also, surprisingly, there hadn't been that much written about it. Um, this is the fastest growing chronic condition in America. 20% of people suffer chronic pain and it hijacks their whole life. And yet, not that much has been written about it. A lot written about dementia and heart disease, cancer, diabetes. Pain has largely been left out of that sort of national dialogue. And I think it's time. I think it's time to tackle it.
Yeah, and I'm glad you did. But what was interesting to me in the introduction, you write that over the past decades, we've learned more than ever about the true nature of pain.
Yeah.
Yet, many of these life saving insights have not been made easily accessible to the public. Why is that, Sanjay?
I think there's a variety of reasons, but I think one of the big ones is the ripple effect of what happens when you have something like an opioid epidemic. This book is not about the opioid epidemic, but the idea that when something becomes such a dominant force within the world, in this case of pain, that not only is it overutilized, which I think everyone would agree, we took far too many opioids, but it also seems to suppress other modalities for pain from coming to the forefront, and even suppressing things that have long been known to be effective modalities from getting as much attention. So there were things that were used for pain prior to opioids that sort of went by the wayside, even though they were highly effective, because everyone measured everything by opioid. Is it going to give me as much relief as a Vicodin or OxyContin? That became the measure by which all other things were sort of gauged. I'll give you one quick example. This one fascinated me is that, again, I just mentioned we're talking about the fastest growing condition in America. And yet, for 27 years, more than a quarter century, there had not been a new pain medication approved. That's remarkable, right? Every year, the FDA approves 40 to 50 new drugs. And yet, there hadn't been a single new pain medication approved since 1998, which was Celebrex at that point. So that's another example, I think, of just these ripple effects of what happens when something becomes so dominant in the world of pain.
It's interesting because you write that while chronic pain can present itself in infinite ways, we have tremendous control in choosing how we'll respond to that pain. That is, we can not only change our relationship with pain, but we can change the nature of pain itself. I found that interesting, and it was hard for me to get my thoughts clear about it until I kept reading the book. So talk about that a little bit at the outset.
I think what is interesting is that I think when it comes to acute pain in the moment, I don't think there's really any disagreement about why that exists evolutionarily. It's a protective mechanism, it's a survival mechanism, and it's a teaching mechanism, right? You touch a hot pan, you know not to do that again. You've learned that lesson. And that's important. That can help you survive. I think the real question, Michael, is why does it then persist in some people? Why would that continue to hurt? And I think that's where you get into this notion of how variable it is person to person. A Mayo Clinic researcher said to me early when I was working on the book in the early days, made this comment which really stuck with me, where he said, chronic pain never occurs in isolation. It always comes with baggage attached, other things attached. And what happens, I think, in a society that has a lot of tools at its disposal, medications, procedures, things like that, is that we start to treat chronic pain like acute pain, and we don't address the other things that are attached to the chronic pain: depression, anxiety, poor sleep, adverse childhood experiences, previous history of pain. All those things, if they're not addressed, you're probably not going to adequately treat the chronic pain. So that is a much more subjective thing than, say, what I do, which is, yesterday I was in the operating room removing herniated disc from somebody who had back pain and leg pain. That makes a lot of sense. But if somebody came in a year later with that sort of pain, maybe they still need an operation, but they probably need a lot more than that, because something in the brain is causing that pain memory to just get played over and over again on a loop. There's no ongoing destruction that's happening in the body. There's no ongoing toxicity. Like when you touch that hot pan, that's a toxic event to your body. It hurts, you get it. Why would it persist 3 months later? What is the lesson there? What is the evolutionary purpose there? That's what makes it so mystifying.
Yeah, what struck me as so interesting when in the beginning of the book you are defining pain, acute, episodic, chronic, you write that pain is an incredibly biological process, but it is mostly a product of the mind, and the mind and body are one. So we'll delve into mind body connection in your 7 steps for improvement, but talk a little bit about pain being mostly a product of the mind in the chronic context.
Yeah, honestly, I think in any context, really, pain is completely developed in the brain. So think of it like this: you have pain signals that immediately travel from wherever the site of injury is. Let's say you sprained your ankle; those pain signals will travel to your spinal cord and then go to your brain, and that's all happening in a split second. The brain then has to decide what to do with that. So it's getting all sorts of signals all the time. It's the brain is like a telescope pointed at the sky, looking for all the stars and trying to see what's going on. I mean, there's as many neurons in the brain as there are stars in the sky, just to give you context. So it's getting all this information coming in, and it has to say, look, is this important information? Is it accurate information? And what do I do with this information? The big question being when it comes to pain is, does that hurt? Does it hurt? So, with regard to spraining your ankle, the brain is deciding whether or not that hurts based on the pain receptors, but also based on seemingly arbitrary things. Did you get a good night's sleep? Are you well fed? Did you have a tough call with a relative? What's the weather like outside? How would those things influence how much pain you objectively experience? Right? That surprises people. But that is exactly what the brain is deciding to do. It is taking all these different factors and in a split second basically making sense of it and saying this hurts. Now therein lies an opportunity, because if you talk to people who are really good at sort of being resilient to pain, oftentimes what they're doing is they're controlling how their brain responds to that pain. The brain is the arbiter of this, and the brain can even create pain. So, phantom limb pain is really instructive. Someone no longer has a limb, and yet it still hurts. How is that even possible? The limb isn't even physically there anymore. So, what exactly is hurting? Well, What is hurting is an area in the brain that is basically sending those signals that for whatever reason it's confused, saying this should still hurt. Point being that the brain is the ultimate arbiter of pain. It can create pain in the ways that I described, and it can also greatly reduce it, if not eliminate it.
So, do we understand chronic pain in some sense, Sanjay, as being a learned behavior?
I think this is one of the great debates, Michael. I think there are people who say this is a glitch. This should not exist. It's not. It's not serving an evolutionary purpose to have someone continue to hurt after an injury they might have had. I'll just use the sprained ankle example. I think people have a general sense that hey, this is going to hurt for a little bit, but then that will go away. But there are a lot of people, again, 1 in 5 people who will have chronic pain. And does that serve a purpose? I think there's a significant number of people in the medical establishment who basically say no, it does not serve a purpose. But I think there's a growing number of people who say, yeah, it probably serves a purpose. We just haven't figured out what that purpose is yet. There's another great book, which maybe you've read, called The Body Keeps the Score. Bessel van der Kolk, who's a friend of mine, wrote that book. And he's a psychiatrist, and he's like, look, there's these experiences we have in our lives. Maybe it's an adverse childhood event. Maybe it's depression from domestic violence, whatever it might be. You may talk to people and say, hey, that's not something that I think about anymore. That was when I was a child. That's not a part of my life anymore, whatever. So they have consciously forgotten it, or they're not thinking about it that much. But you know what? The body keeps the score. So even though your conscious mind may have forgotten something, that persistent back pain, that persistent hip pain may still be a result of some of those earlier experiences in your life. So maybe there's a lesson in there, right? So maybe that's the lesson, is that you have to go back and address those things in your life to be able to deal with your chronic pain. The pain is a signal. That's what the pain is. And in this case, it's a signal to deal with something that you haven't dealt with in your own life. That's Bessel's point. But this is a great source of debate, I think, within the pain community.
But so would imply, it seems to me, that you can train your brain to switch signals from threat to safe. You've written about this in the book here, so let's talk a little bit about it.
The idea that if someone has chronic pain and they get all the imaging done, let's say they have back pain or whatever, and they get an MRI and they get a neurological exam, and there's nothing that sort of pops out as being problematic, then you're sort of left with this question, like what is still driving the pain there? And the idea that somehow it is still being driven by a mechanism that you're not fully understanding, I think I think that's where the field is basically headed. Is that what you're asking me?
Yes. Yes.
Yeah. And to put a punctuation mark on it, I think if someone has deep emotional pain, okay, we call it the pain of loneliness. They're lonely, and you look at how their brains respond to isolation. What you find is very interesting in that the same areas of the brain that activate during physical pain, there's a huge overlap with those areas of the brain in people who have emotional pain or the pain of loneliness, for example. So again, the brain is not distinguishing between these types of pain. Emotional pain, physical pain, mental pain, psychic pain. In many ways, for the brain, they're all kind of the same, which is why it hurts. You can have physical pain seemingly associated with loneliness.
It's interesting. When I was reading this, it struck me that a lot of what we're going to talk about in respect of pain and pain management is similar to the way you treat obsessive compulsive disorder, the OCD. The Buddhist nun that I follow, Pema Chodron, has her 4 R's: recognizing, refraining, sort of relaxing into the urge, and then resolving or repeating the process. You have 3 R's: reframe, replace, and reset. I didn't realize that you were so Buddhist, Sanjay. But talk about the 3 R's and what are we talking about here?
I think one of the great learnings for me personally when I was working on the book was this idea that we're sort of circling around, which is that if someone has chronic pain, I think that the idea fundamentally and understandably is that something terrible is continuing to happen in my body. And that makes it hurt. But if you can reframe that and say, hey, there is no ongoing assault happening on my body. This is purely a product of the mind. And I'll say this now and I'll repeat it later. To say that it's all in your mind is not to say that it's all in your head. And I think that was one of the challenges, I think, for people who wrote about this topic decades ago, was they brought up what I thought was an accurate point of psychosomatic illness and this lack of divide between the brain and the body when it comes to pain. They overlap in the brain, as I just explained. It's the brain doesn't distinguish. But I think that this idea felt minimizing to people to call it psychosomatic. You're just saying it's all in my head. You're minimizing my pain. That's certainly not my intent, and I don't think it was the intent of people ahead of me, like John Sarno or others that have written about this. He wrote a book called The Divided Brain. But I think it does make the case that you need to reframe and reset what is happening here and remind yourself that there's not this persistent toxicity in your body. That goes a long way toward helping people recover from their pain. The opposite of that, just to give context, is that let's say you injured yourself and now your brain is going through this process of deciding, does this hurt? Let's say you just cut yourself badly with a knife. Your brain is deciding, does that hurt? And right, like for a split second, you may know, Michael, that it doesn't hurt right away when you cut. It takes just a split second for it to, that really hurts. Now, if you look down at your hand and you see a lot of blood, that's going to make it hurt even more. So that's sort of the opposite reframing. Now you reframe this like, this is a real injury. I've really injured myself. That hurts. It's the signal to take action. The opposite of that would be, hey, look, there's nothing here. There's no swelling, there's no blood, there's nothing. That's sort of this constant reframing that people need to be doing when it comes to chronic pain in particular.
And then you say replace and reset. What are replace and reset?
So if you're taking away a particular sort of notion here that there is no ongoing assault on my body, what do you replace that with? One example would be, hey, look, I've injured myself. I need to go rest. I need to just take it easy. And instead replacing that with this idea that if your bone isn't broken and there's not blood or you haven't torn a ligament, you should probably be moving. Mobilization is probably going to be a much better option for you than staying sedentary. That's an example of changing how you're approaching this. It's a challenging thing to do in the moment. 3 months, by the way, is considered chronic pain. If it hasn't gone away in 3 months, or if it hasn't gone away in 6 months where you're suffering pain every other day. But for many people who may be listening to your podcast, they've had chronic pain for decades. So this idea that replacing that chronic pain with something else, moving instead of sitting and lying, that's an example of that.
Mm. And so by doing so, you reset your...
Yeah, so that's the final R, is that you like to meditate, you like to do things. What's interesting is that people want evidence that a reset can happen in their brains. One study that's come out recently, specifically on pain that maybe you saw, is that people who are meditators, who regularly meditate, they have objective changes in their brain. They have thickening in areas of the brain, in several areas of the brain, but one of those areas is just behind what is called the periaqueductal parade. Don't need to remember that term, but that is a pain modulator in the brain. And that is an area that can actually become more resilient to pain in response to regular meditation. So that's an example of all 3 R's then sort of coming together.
Yeah, it made me smile when I was reading the book and you said that you get a cut and you don't know what it is and you look at it and then you respond, and you talked about children. And I was at a birthday party and I saw this little girl running, and then she fell, sort of at the foot of her mother. And she sort of like looked up to her mom to say, how should I respond to having fallen? And if the mom said, oh, you're fine, get up. That's part of life. The kid gets up, doesn't cry, and starts running again. If the mother says, oh my God, you've fallen, then that's this learned behavior that you are talking about, yes?
Absolutely, and that's part of the brain, again, looking for all the cues within a short time to determine if something really hurts. And one of those cues is if you injured yourself and you get up and you look around and you see a lot of concerned faces looking at you, that's probably going to make it hurt more as well. And I think kids are a great example of that, but that happens in adults as well. Even now for me, if I've had some sort of injury, I'll immediately sort of like kind of gauge the room to say, oh, and people are like, oh, that looked. I was on my bike not that long ago, had what I thought was a significant wipeout, and as I'm sort of collecting myself off the pavement, I just see these horrified looking faces, and I realize that basically the right side of my body had lost its skin, as I skidded across the road at a high speed. Didn't actually hurt as much. It was like it stung, but then as I saw those horrified faces and the pain started to settle in, I realized how bad it was. So yeah, it's all part of that processing that the brain is doing. And by the way, the brain doesn't always get it. Sometimes it greatly exaggerates the level of pain. Sometimes it underestimates the level of pain. Sometimes it switches the location of the pain entirely. So, like the example I give in the book is someone having a heart attack and their jaw hurts and their left arm hurts. That or if your right shoulder hurts, that might be an indication of gallbladder pain. So it's sort of these referred pains that can be a bit confusing as well. But again, that's just the brain trying its best to do its job.
Yeah, you're right that the brain sometimes misinterprets pain because it doesn't recognize or trust the source of the information it's getting.
Yeah, there's a lot of analogies to our real life. I say in some ways, I gave this example. I was trying to figure out how best to frame this, but it's like your brain is consistently and constantly scrolling a social media feed. Just scroll, 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 scroll. Most of the information it brings in is not relevant, and it discards it easily. It has no relevance. Every now and then, something particularly incendiary will pop into your social media feed, and then the brain has to decide: is this valid? Is it real? Is it accurate? Is it fake news, so to speak? But if it's not fake news, then how best to respond to this? And I'm not just talking about the reflexive action of moving your hand away from a hot pan. You would do that regardless. That's more your spinal cord reflex. I'm talking about the very basic question of, does it hurt? And what am I going to do with this information now that I've decided it does or it doesn't hurt?
It was so interesting to me that you write that pain sufferers generally fare better when they're given a basic understanding of this neuroscience that we're talking about, the neuroscience of pain. So talk about this, because you talk a lot about the doctor-patient relationship in respect of chronic pain and understanding what's going on here and how that helps.
Yeah, this is interesting, and this is something that I even saw in my own clinic as I'm seeing patients in the office, talking to them. You get to this point where someone might have pain, and they're getting all sorts of testing and exams and all that, and then at some point, the realization is that all those scans are normal. There's nothing that's a obvious problem. Now, again, that's not to diminish their pain. Their pain is very real, despite what the scans may show. But what you find is that when you tell people, hey, look, I know you're worried because pain is a signal, and so you're worried that your body is sending you a signal that there's something terribly wrong. And what I'm telling you is that we've looked and there's not something terribly wrong. It's not to say that your pain is made up. That is exactly how pain works. It is a signal. But once they hear sort of the neuroscience of pain, here's why you still might be experiencing pain, even though there's not a herniated disc or a broken bone, whatever it might be. I think it relieves their anxiety to some extent, because if you're hurting on a regular basis, it makes total sense that you might think that my body is betraying me in some way. Something terrible is happening inside my body. So trying to alleviate that anxiety, I think, goes a long way towards mitigating pain. Again, I'll keep repeating this. It's not to say that their pain isn't real. It's not to say that it's all in their head. But once they understand how pain works and they understand that there's not an ongoing toxic force inside their body, it does seem to help.
Yeah, in my personal case, I went up to Mayo a few months ago because I have this fibromyalgia diagnosis. And I wanted to know what they thought about that. My local doctor said, well, you've got fibromyalgia, take some pain killer, some NSAID, and that's all we can do. And I thought, that can't be all we can do. So I went up to Mayo because they have that big fibromyalgia clinic there. And they said, well, the one thing that you really need to understand is that this is a disease of the brain, fibromyalgia, more than the body, in the sense that what you're experiencing derives more from the brain than a physical injury. And my diagnosis at the end was fibromyalgia. And my prescription was get more exercise, get better sleep, take a meditation or yoga or Tai Chi class. And if you need to take Tylenol or Lyrica or something, fine, but understand what's going on. And it was very instructive for me to understand the neuroscience, but it also, to your exact point, seemed to alleviate the pain. I wasn't as anxious about what I was experiencing now that I understood what was going on.
Yeah, I think in this case, knowledge can be really helpful in terms of alleviating pain. But it also, I think, gets at this point, which I think you're alluding to, which is that we tend to think of things in a unidirectional way. So, for example, I'm not sleeping well. I'm not sleeping well because I have pain. That makes total sense, right? I think people fundamentally understand that. But if I say to you simply, hey, think about this not just in a unidirectional way, but think of this in a bidirectional way. What that means is that you're not sleeping because of your pain, but your pain may also be worse because you're not getting good sleep. I think the vast majority of people would target their pain. So I can just get my pain under control. That's going to help with my sleep. Sleep is the symptom, not the cause in that equation. But if I tell you that poor sleep or undertreated depression or anxiety directly affects how much pain you suffer moment to moment, day to day, it is a little bit of a hard thing for people to get their head around because they think of the divided brain. They think of mind body sort of separation. But the brain doesn't care. The brain is lumping it all together. So poor sleep, yeah, that's going to make you hurt more the next day. Yeah, maybe the pain made you have poor sleep, but it's bi-directional. So if you went to a pain doctor and they said, hey, I'm doing nothing for your pain, I'm just going to focus on your sleep, you'd say, what that, like, how does that going to help me? But it does. And I think that's where just over the last decade or so, that's what you hear a lot in pain clinics now. And what is special about a pain doctor versus a different doctor? I think a few things. I mean, they're saints, if you ask me, because they take care of patients who are some of the most, these are suffering patients. They've been suffering for a long time. They spend the time with these patients, but they also really lean into this bi-directional nature of pain. So let's look at all the other things in your life and understand that we're not just being holistic here. We're sort of really diving into this idea that those things are worsening your pain as well. And unless we address those things, you're never going to fully get rid of your pain.
Yeah, when I was up at that fibromyalgia clinic, there were people who were in terrible, terrible shape. And what I came away with was this notion that they are their pain. That's all they know. That being in pain has defined their entire identity. And they're stuck in that endless loop that the male people hopefully can help them get out of. But I think that's what you're talking about to a certain extent, that people become their pain and they don't realize really what the true source of what their pain might be.
Absolutely, and even made harder by the fact that the brain is not distinguishing it for them. Like if the brain really distinguished, the pain of isolation and loneliness from the pain of injuring yourself physically, it might be easier for humans to parse those things out. But they're all interrelated. So you really have to address both those things. This point that you're making about you become your pain, though, for me personally, I will tell you, Michael, that was a bit of an insight, and I think it really has to do with the idea that we're in some ways we're talking about pain, but what we're really talking about is suffering. So suffering and pain are often used synonymously, but I think they're different. Pain is a much more functional sort of word. that we try and measure. You ask people to describe it on a scale of 1 to 10 even. Suffering is a much more personal experience. And, you could have a diagnosis of plaques in your blood vessels leading to your heart. So now you have heart disease. So you have this condition now, heart disease. Is it causing you day-to-day suffering? Well, hopefully not, right? I mean, you're living your regular life. Now you're probably going to eat better. You may take a cholesterol-lowering agent. You may do these things. With pain, because of its association with suffering, it can hijack your entire life. I went through this with my own family members, even while writing the book, and that was a bit of an eye opener, because even as a doctor, I'm taking care of patients, and I see them for maybe an hour in the office. I don't know what their lives are like outside of the hospital, outside of the clinic. When it happens to your own family member, and I'm basically living there and feeling helpless and watching pain slowly hijack, in that case, my mom's life, that line of pain and suffering becoming blurred was really, really apparent to me.
Yeah. And suffering is a great word to describe what chronic pain becomes for people when they become hopeless
Yes.
around it and can't address what we'll talk about after the break, what to do about it, your 7 pillars for getting a handle on this. But the last question I want to ask before we take that break is, do men and women experience pain in the same way?
That's a great question, and the answer is yes, but not in the ways that people necessarily think. It seems to be more situational than it does sort of be generic in terms of saying, hey, certain gender is going to be more resilient to pain, that they treat it more subjective, or they have less suffering associated with it. So there do appear to be differences, but when I was writing the book, there wasn't anything concrete enough for me to say, hey, look, here's an obvious gender difference when it comes to pain. Sometimes men can tolerate pain more, but complain about it more bitterly at the same time. So what does that mean? Because pain is pain, pain is suffering, pain is unpleasantness, pain is inconvenient. So maybe it's more inconvenient for people than actual suffering, but it's pain nonetheless. So it really depended on taking the time in those studies to really not only define pain, but to fully understand how the individual who's being studied define pain. Like, this doesn't really hurt, but I am really bothered by it, right? Or as Eric Garland talks about UCSD, whenever he measures pain, he says pain score and unpleasantness score. I want to look at both those things, because to some people, maybe they sound like the same thing, but for, I think, these neuroscientists, they were different enough to define what people were talking about a little differently.
Yeah, so one subjective evaluation of their own pain has to be measured.
It has to be measured, but like unpleasantness might be the way that I describe it, whereas my wife may say that is a searing lightning bolt-like thing that I'm experiencing in my arm. So a truly sort of descriptive pain sort of adjective she's using, whereas for me it's a nuisance. Okay, so nuisance is that the same thing? It depends who you ask.
Let's take our first break, and then we're going to come back to the 7 strategies to essentially train your brain to change the pain circuitry. We'll be right back. We're back. We're talking with Dr. Sanjay Gupta about his new, wonderfully instructive book, It Doesn't Have to Hurt, Your Smart Guide to a Pain-Free Life. So before the break, we were talking about pain. What is it? How does your brain process it? What are the implications of how it's processed on your life? And part 2 of your book is, well, fine, now that we understand this, which is really important, as we discuss, understanding the neuroscience of this matters. You have 7 strategies to essentially train your brain to change the pain. And it's very interesting. I said to you before we started that I keep my notes of our conversations and I return to them when I'm almost like a medical dictionary might be. And I went back to Keep Sharp, the previous book we discussed, and you had 5 pillars of maintaining brain health: movement, purpose, learning and discovery, sleep and relaxation, nourishment, and connection. I thought, well, that seems really relevant to the 7 pillars of this. proving, of course, that we're integrated wholes. We're not separate parts. So let's start with reset number one. Reset your mind your brain. You call it. What's that about?
If you buy into this notion, and I think you should, that all pain is sort of determined in the brain, that means that any kind of healing that you're going to sort of try and chase, especially for chronic pain, you can't ignore the brain. You have to make sure that you're addressing what is happening in the brain as well. Some of that might be in the form of like trying to build resilience, like the MORE protocol, for example, which I write about, which is mindfulness oriented recovery enhancement that can help build resilience in the brain in objective ways. But I think a lot of it also has to do with this idea that if there's this gigantic overlap between physical pain and these other kinds of pain, emotional, psychic, existential, whatever it might be, to me, it made perfect sense that if you're not addressing those things as well, your brain is still going to light up in those exact areas of the brain that we typically associate with physical pain. So you have to mind your brain. You have to be thinking about your brain as a first step.
And you're right. Every part of us is wired. Every part of our brain, I suppose, every part of our brain is wired not only for pain, but also for pain relief. So we talked about the neuroscience of understanding pain, but that the brain is, neutral in a sense. Send me data like a machine learning thing, and I'll try to understand it and respond to it. So if it's trainable for understanding what is pain, to your point, it's trainable for what is pain relief. Yes.
Neuroplasticity, which is this concept that I think a lot of people have now heard of, the idea that your brain changes in response to stimuli and all that. That's an inherently neutral process. We'd love to think of it as benevolent. I mean, it's always moving us towards this better thing, but it's very dependent on the inputs that we give it. Our brain changes in response to the inputs that we give it. So, the concrete example would be that you're, playing a game and you're getting better and better at that game, and your brain is changing in response to that. The more roads are being laid down to make you even better at that game. But the same thing happens with pain and with all the other things. Like if you, there is a memory loop that somebody described to me when it came to pain. You said this sounds like obsessive compulsive component. In some ways, I think it's in some ways more even post-traumatic stress component. Like, why do you continue to replay certain memories in your head after a particularly traumatic event? What purpose does that serve? A car accident or my bike accident, whatever it might be. Why would I keep thinking about that? I mean, I got the lesson. I don't fall off your bike. Be careful. You're going down hills. Don't go too fast. Whatever it might be. Got it. Do I need to keep being reminded of that? And I think it's the same thing here. Understanding that your brain is very plastic in this regard, and quickly it can start to lay down memories that become increasingly harder to forget. That's what you're trying to avoid. You don't want pain to be a memory that you can't forget.
Yeah. If it's a continuous loop and every time you wake up each morning, you're in Groundhog Day with your brain, you've got to change the input or change your understanding of what's going on, right? To mind your brain.
Somebody said to me, I'll tell you, it was an interesting insight, and they almost made this comment in an offhanded way during an interview, but they said people with extraordinarily good memory are more likely to deal with chronic pain. And I thought, wow, let me just get my head around that. That's interesting. So you're really good at remembering things. And one of those things that you're really good at remembering is pain. That's wild to think about, because you think of pain as just a sensation. I'm not remembering the color of someone's shirt that they were wearing when I met them. I'm thinking about a deeply mysterious human sensation, but I'm really good at remembering what that feels like. And then when I remember what that feels like, the brain memory loop just keeps getting played over and over again. And I experience the pain just by remembering it.
Yeah. And it's why when I was listening to this, I had a vision in my mind of someone lying on a Freudian psychiatrist's couch saying, let me talk about this event in my childhood as it relates to physical pain.
Yeah. This is the conversation you and I are having right now is a conversation that I think has been had within medicine for a few decades, but it's never really emerged as a main mainstream way of thinking about things. And in part because I think there was so much stigma around the idea that the mind and body are so connected, and that if you said something was in your mind, that it immediately felt minimizing to someone's real world experience. It's all in your head. It's
Yeah,
all in your head. Yeah, but it is all in your head. But I do think this idea that if you can unearth some of these experiences in your life that maybe you don't think about, they're not at the forefront of your brain certainly, but they may be contributing to your pain in some way. It's what John Sarno talked about. It's what Bessel van der Kolk talked about. That's what I write about in the book as well. And I'll say it for the third time. It should not be interpreted as a minimization of anyone's pain. The pain is real. It's very real. But what exactly is driving it is what we're talking about here.
exactly. And especially so because your brain doesn't hurt, if you will, like your sprained ankle in your example. Your ankle hurts. Your brain doesn't hurt. Your brain is sending signals around how to interpret that pain, but your brain doesn't hurt. I'm not talking about a mild headache or anything, but
Right.
what we're talking about doesn't hurt in your brain.
That's right. The brain is sort of like the supercomputer here. It's neutral again. So it's not trying to torture you or not trying to alleviate you. It's trying to make the best assessment based on all the data. It is interesting, by the way, as a little bit of a side note, that the brain itself, which is the great arbiter of all these things, does not have pain sensors itself. So like I can do awake brain surgery on somebody. When we do awake brain surgery, I do have to numb up the scalp because the scalp hurts when you make an incision. But that's really about it. When we're actually operating on the brain, the patient can be wide awake, not experiencing pain.
Yeah, maybe the brain would behave better if it had a little pain. So what it dishes out, it can get on the rebound end of it.
That's funny. Yeah.
So the second of your resets is your mind body connection. You call it befriend your body. So talk about that, please.
Well, as much as we're talking about the brain, there's no question there are things that we can do in our lives to make us more resilient to pain, or to at least have it not hurt as long or as much when we do have injuries. One of the things that sort of fascinated me, and this was a result of a lot of discussion with experts in this area, but around all of our organs and muscles, we have something known as the fascia, which is like a thick envelope of tissue that envelops your muscles. It serves purpose to basically hold you in place. As we get older, that myofascia becomes tougher, more rigid, and less forgiving. So think about that. Now it's enveloping your muscle. In the past, if you injured your muscle and you had a really pliable myofascia, it would sort of stretch in response to the swelling in your muscle after an injury. If that myofascia is tougher and more rigid, it doesn't stretch as much, doesn't give as much. And that can be associated with pain. So, the example that a lot of people know is like they get plantar fasciitis or something like that. The bottom of your feet really hurt if you've ever had that. It's painful. It feels like knives going into the bottom of your foot. And you think, well, it feels like a sharp thing in the bottom of my foot. That's actually just your myofascia, your plantar fascia. And so opening it up, sometimes people will be told to like roll a golf ball underneath their feet, and just sort of steadily open up that fascia. That seems to make the pain get better and eventually go away. Think about that same concept in different areas of your body. You go to pain clinics, and one of the things they're telling their patients to do, even on other areas of the body that aren't sources of pain, is to foam roll regularly. Just use foam rollers on a regular basis to kind of keep that myofascia as pliable as possible. And that's an example of befriending your body. There's all sorts of ways to befriend your body. That's a really tangible one. But certainly how we eat, how we move, how we rest, all those things play an objective role in terms of how much we actually experience pain.
Yeah, and it seemed to me as I read it, though it wasn't a specific reset, struck me as a subset of this is reset your stress, because it seemed to me that chronic stress fuels inflammation, and that triggers this loop that we've been talking about in the brain, and brain signals get sent. Do I have that right?
There's all sorts of things that are probably fueling this idea of the memories becoming a loop. And stress is certainly one of them. It's interesting. Just as a little bit of a sidebar, there was a study that basically was showing that people who came into the emergency room after some sort of traumatic injury, let's say they got hit by a car on their bike or something like that, one of the things that they would try and do for people, if they could, was give them a little beta blocker. A beta blocker is something that lowers your heart rate and your blood pressure. Okay, now you wouldn't want to do that if someone was bleeding, for example, because that could put them into a state of shock. But let's say they could tolerate some beta blocking. What you're really doing is mitigating, reducing some of the stress hormones that are activating in your brain and in your body. You're sort of lowering that epinephrine surge. And we know that when people are highly stressed during traumatic events, they are more likely to imprint the memory of that event into their memory centers in their brain. And that probably contributes to this persistent looping of the memory again. The thing is, like Michael, I think a lot of these things are intuitive to people. Yeah, I don't want stress. I don't want too much stress. I know I need some, but why? What is it actually doing with respect to pain? That's what I wanted to get at. I wanted to get at the why behind the what's here, and that was an example of that.
And that's why the book is so brilliant, and I think is not only an easy read cover to cover, but is a wonderful source because you can go back to say, all right, well, I've got to reset my stress. What are the techniques? And you've got mindfulness and meditation, deep breathing, music, relaxation. You're saying here are things, reader, that if you consciously now are aware of the neuroscience that we're talking about, let's try listening to music and see what impact that has. What about um, mindfulness, deep breathing, box of four breaths, four
Yeah,
in, six out sort of stuff, right?
absolutely. What strikes me in general about this topic is that I think most people recognize that there's some virtue in those things, right? But they didn't know why. And if you didn't know why, or you say, hey, the evidence is limited on meditation for pain, then you might think, well, uh, until there's evidence around this, I'm not really going to engage. Fair enough. I mean, everyone's going to treat these things differently. But I think what that has been for researchers in this pain community over the last decade is a clarion call then to go try and gather some of this evidence. So, and because it's such a universal experience, a lot of that evidence is gathered in the United States, but also in many other countries around the world. So, for example, I write about this group of cardiothoracic surgeons in Istanbul, Turkey. They try and use opioids very sparingly, even after open heart surgery. Okay, and you think, wow, I mean that seems ridiculous. You just cut somebody's chest open, operated on their heart. That sounds like one of the most painful things, and it is. But they said, hey, look, we're going to try other strategies, including music. So this particular group of cardiothoracic surgeons in the recovery room, so they've just operated on the patient gets wheeled to recovery room. They stroll in a little bit later with instruments, and they are playing music for these, and it's very culturally appropriate music for someone's own taste. So there's certain instruments in Turkey that are really recognizable to people in terms of their calming sort of tones and calming melodies that are associated with those tones. And they play that, and then they collect data because patients there in a recovery unit, right? So everything is being measured, respiration rates being measured, heart rates being measured, blood pressure is being measured, and they have real data that they see how does the person respond to music. It was fascinating, and as you might guess, the reason I wrote about it was because it was quite extraordinary. You had patients who never required opioids, okay, who had this massive operation performed on them. That sounds outrageous in the United States, and people may even say it's medical malpractice. Like, how could you not give me opioid pain medication after this very painful thing? I get it, but I will remind you as well that there are countries around the world where that is not commonly done. I had a colonoscopy a few years ago. Everyone in the United States gets colonoscopy, gets propofol, and that's the milk of amnesia stuff that makes your basically completely unaware of the experience you just had. Guess what? They don't use propofol in Japan for the exact same procedure. Only 6% of people in Finland use propofol. How did pain become so culturally appropriated if it's a universal human experience? And that's because, it's highly variable, not only among populations of people, but even within the same person day to day. And I think that that's one of the great lessons here. When it comes to mindfulness specifically, people wanted data. So, Eric Garland and his team train 1,000 practitioners who go out into the community, basically dealing and helping people with chronic pain. And they said, okay, how do we contextualize the benefit of this, of going through a mindfulness oriented recovery therapy? And what they said is basically when we contextualize it, we found that a episode of meditation, call it a dose of meditation, in some ways provided the same pain relief as 5 milligrams of OxyContin. Okay, now we're talking. Now we have something we can dig our teeth into. How much does it help? Well, OxyContin doesn't help everybody, doesn't last forever in anybody, and some could say the same about meditation. It's not going to help everybody, but for some people, it was able to provide the same pain relief as an opioid. So you're starting to see this blurring of lines between what is considered opioid therapy, which is the gold standard, versus all these other things.
Yeah, it's unbelievable. And I read on the point of music, which I found so fascinating in your book. I read this little article in the Science News. Why I read Science News, I can't explain. But it was talking about how people who listen to music on a regular basis had a drop in dementia risk.
Hmm.
So, go figure.
I, I believe it. I mean, it's a different topic, but music is one of those few things that can activate the entire brain. When you stick someone in a functional MRI scanner and you just tell them to think about music, not sing it, not play it, just think about music, you see all these different areas of the brain light up. The lyrics to the song, the words, if you will, are probably coming from your left temporal lobe. Putting them into some sort of melody is probably coming from your right parietal lobe. So it's right away crossing the inner hemispheric fissure, crossing one side of the brain to the other. Not many things do that. You add a beat to it, like an actual beat to it. You are probably activating your cerebellum, which is the back of your brain. So as people have described it to me, it's kind of like if you look at a functional MRI, it's kind of like the sky just lights up, in all these different areas. Whereas most activities in a functional MRI scanner will cause a very specific area of the brain to preferentially light up. Music seems to light up all these areas, which is probably why it's associated with such neuro benefits. Gabby Giffords, after she got shot in the head, part of her rehab I was with her. She was getting rehab involving music therapy, and she had been shot. She had a hard time speaking. She had a hard time moving, balancing herself. The song that they were playing was "When the Saints Come Marching In," and she was singing it. She was singing the song, and then she stood up and started, just sort of stomping her feet in response to the beat of the song. And I guarantee if you were to have put her in a functional MRI scanner at that point, you would have seen a remarkable form of therapy that was actually lighting up all these areas of the brain. Very hard to do with any other kind of therapy.
It's great. Well, let's take our second break and now come back and try to get through the remainder of the resets. So we'll be right back. We're back. We're speaking with Sanjay Gupta about his newest book, It Doesn't Have to Hurt, Your Smart Guide to a Pain-Free Life. We're talking about the 7 pillars that underlie your approach to chronic pain. And the next one I want to talk to, which is sort of related exactly to what we were talking about, which is move more, reset your body. Talk about it and the MEAT notion.
So here's how that section started. You'll appreciate the backstory. The question that I kept coming back to as I was writing is, could you predict who's more likely to suffer chronic pain? That was the question. 2 people, same injury, same insult, whatever to their body. One person, suffers pain a day or so, goes away. The other person, the pain just never goes away or lasts for months. Why? What's the difference? And as you might guess, this is a wildly important question in the world of medicine overall, but certainly pain medicine. And researchers have been looking into this. So they were measuring all these different things in people. And then when they had a pain episode, figuring out what those things they had measured were protective or not against pain. Thing that kept popping out for some of these researchers was inflammation. Now, that's not surprising, inflammation being associated with pain. But the thing is that it was associated in almost the exact opposite way that you think it would be. So people who had the lowest levels of inflammation at the time of injury were the most likely to have chronic pain. Okay? Lowest levels of inflammation. Um, that was surprising. That was revelatory, I think, in the world of pain medicine. Because what do we do when we're injured, when we've injured ourselves? Or take the sprained ankle example again. You tend to do several things to reduce inflammation. RICE is the protocol a lot of people are familiar with, which stands for rest, ice, compress, and elevate. If you think about what all those things do, it decreases blood flow to the area of injury, decreases inflammation, and you can understand why that feels beneficial in the moment. You have swelling, it's red, it hurts, so I'm just going to rest it. But again, I just told you that if you reduce inflammation a lot at the time of injury, it's more likely you're going to have chronic pain. So it's almost like you're reducing the pain in the moment, but it's not like it's going away. It's potentially going to last longer as a result of that. So if you go to sports medicine clinics now, you go to pain clinics, I think the guidance is changing, and it's changing pretty quickly. So instead of RICE, for example, as an acronym, MEAT is the acronym a lot of people talk about, which is mobilization, exercise, analgesia, and treatment. Treatment like in the form of massage, for example. So the idea that, hey, look, I've sprained my ankle. I think everybody thinks just put it up, rest it, wrap it if you need to. But if I tell you instead, mobilize that, get that thing moving, let those inflammatory molecules that are rushing to the area of injury do their work, do their job. They do their job in the moment. Uh, it'll help reduce the chance that that pain will linger too long.
Hmm.
That was fascinating to me because it sort of upended, I think, a very, very commonly given recommendation when someone has an injury.
Yeah, I know this in my own life. When I was a high school and college soccer player, I got my meniscus torn, and this was a long time ago. And they put me in a plaster cast for 6 weeks, completely immobilized. Last year, when I had that knee finally replaced, they said, "All right, well, fine. You can leave the hospital uh, shortly, but you have to walk out. Essentially, we want you to start walking. You know, 10 minutes after surgery." I said, "Wait a second. Where's the plaster cast? People can come over and sign." He said, "No,
Right.
that's
Yeah.
that those days are gone. You've got to move immediately, exercise immediately." Um, to your
Yeah.
exact
I mean,
point.
look, if you've broken your ankle, I want to be clear, then you probably shouldn't be walking on it, obviously. But we're talking about 90% of injuries here where you don't have that. And I think as a general rule, people think to themselves right now, you don't see as many casts as I used to. I just don't, because the idea of mobilization early. So even if there is a cast, it's taken off much earlier if it's placed at all.
Yeah. So the next two I want to take in combination, which is reset your sleep, reset your nutrition. So sleep and eat well. So talk about that.
This gets back to that notion of the bidirectional relationship again. The idea that we think of pain being something that negatively affects sleep, and it can be, but that sleep is also something that negatively affects pain in very objective and significant ways. So targeting sleep first, even in people who are dealing with chronic pain, that may not be the way that they have thought about things. They certainly want good sleep, but the way that they've approached it is to tackle the pain first, take pain meds before bed or whatever it might be. And again, I just want to be clear, in some situations that might be appropriate. What has been neglected here, and what I tried to reinforce, is the idea that with many of these things, because of it being bidirectional, you have to address those things as well, significantly, and maybe sometimes even first before you're dealing with the pain. Nutrition is very interesting because I just made this comment about inflammation, and inflammation is to many people a four-letter word. The type of inflammation that your body creates in response to an injury is different than the tons of pro-inflammatory foods that we all eat. 70% of most people's diet nowadays is ultra-processed foods. That those are bad for lots of reasons, but one of the reasons they are bad is because they are very pro-inflammatory. The body doesn't love them. They treat many of these foods as foreign objects, and as a result, you're just increasing inflammation in your body. So, what would otherwise be innocuous injuries are more likely to hurt because you just have a higher baseline level of inflammation. On a personal note, I'll say that my wife is, she's dealt with all kinds of food allergies and issues most of her life. Some of them identified, in more recent years. And as a result, because we eat most of our meals together, I generally eat what she eats, which is a pretty restrictive diet. It's a pretty anti-inflammatory, pretty restrictive diet. And by the way, she's found wonderful ways to make it taste good. So it's a good good diet, a tasty diet. But what I found was that when I started adopting this diet, I hurt less too. It wasn't my objective. My objective was to show camaraderie with my wife, and hey, I'm in it with you. But like getting out of bed in the morning, it's always like a little ache, especially if I'd had a hard workout the night or day before. If I missed a step or I hit just my heel on the step, like that heel would hurt for a while. And now I find, as a guy in my mid 50s, when I eat the way that my wife does, I just don't hurt as much. Right now, as I'm talking to you, I'm doing a little self-assessment on my body. Feet, legs, calves, everything. I've been sitting here talking to you for over an hour. Nothing hurts. A little bit of left shoulder pain, which I have had for a while, usually in response to my workouts. Five years ago, before I started doing this, if I sat down and assessed my body, there'd be several points of nuisance, I would call them. Were they outright crippling pain? No, but they were a nuisance. They were causing me a bit of suffering, that I didn't love. It wasn't inhibitory to my life. Those things have largely gone away.
It's interesting. When my wife and I are in Atlanta next, we'll call you, we'll go out to dinner, compare. My wife has gluten and dairy restrictions, and she's allergic to the allium family, which is garlic and onion. And so that's a challenge.
My wife has an onion allergy. It's not garlic, but it is onions and scallions and everything in the onion family. So, and cinnamon and Salma Peru and tomatoes. So certain citrus things she's allergic to. So it's challenging sometimes, but like I said, she makes it work.
Yeah, well, when we go out to dinner, we can forage together.
There you go.
So the next one I want to talk about also relates back to your keep sharp brain health, which is reset your relationships, cultivate connection. For me, when I read Keep Sharp, I thought, my God, this is revelatory in respect to brain health and trying to protect it from deteriorating like a muscle that's not taken to the gym. But I never thought of cultivating connections in connection with chronic pain. So can you talk about what you learned here?
The brain does not distinguish these different types of pain. I mean, that is the headline for me. So the pain of isolation or loneliness, which by the way is self-reported, right? Meaning you could be surrounded by people and still feel incredibly lonely. And our former Surgeon General wrote about this. I think it's a topic that a lot of people are paying more attention to now, maybe because of the pandemic and seeing the pain of social isolation during the pandemic just really, I think, emerged to the forefront of a lot of people's minds. But the headline here is that when someone is dealing with that in their life, that can physically hurt, okay? It can physically hurt on its own, or it can exacerbate other physical pains that you might have. So it can take something that would otherwise not be that significant a pain in your life and make it much worse. So cultivating social connection, is a good idea all around. We know that it generates more oxytocin in the brain. That oxytocin can be helpful for creating more what are called neurotrophic factors, which help you build new brain cells. But it also helps reduce the amount of pain that you have. I won't call it physical or emotional or psychic or existential pain, because they're all the same in the brain. So by cultivating those social connections, you can reduce the amount of pain that you suffer overall.
Yeah, the sentence that you wrote, you said people with chronic pain are much more vulnerable to social isolation and experience of rejection and disconnection, and that reliably amplifies pain.
That's right. And so that you're someone who's in pain all the time, and we talked about the idea that it hijacks your life. I mean, look, you might have again plaques in your blood vessels. You're probably not leading every conversation that you have with somebody talking about that. If you're in pain and it's uncomfortable just to sit and talk to someone, no doubt that'll be part of that conversation. And ultimately, I hate to say it, but people, they may not want to spend as much time with you if every time you get together with them, you're just talking about your pain. So it becomes this self perpetuating cycle where you have pain, you gradually become more isolated as a result of that pain, and then that amplifies the pain.
Yeah.
So, and again, it's bidirectional. So that amplification of pain is occurring from the isolation, but the isolation is in part being driven by the pain as well.
What are the implications of this in the workplace? That we hear a lot about workplace wellness, and if people are suffering in this way, in this sort of silent, chronic pain, does it have implications? Have you seen it like in your work environments? People who are suffering this way, maybe silently, does it have impact that way?
Oh, yeah, it definitely has impact. I will say we're at a phase in our society where I think it is still stigmatized to the point where people won't talk about it for fear of being seen as weak or complaining or things like that. So it's part of the reason I give these pain doctors so much credit in the book. They are the ones that often are able to look at the entire picture and determine what all the relationships are with the pain and deal with it. But I think we'll get to the point where we think of pain the way we think of other chronic conditions. But right now, it is seen almost purely as a body phenomenon, not a mind phenomenon. And oftentimes, if someone has persistent pain, despite the fact that the injury was much earlier, that is often seen as a sign of weakness still within the individual, lack of will, to just sort of power through it or whatever. So, do I see it? Perhaps I see it more than others because I'm a doctor and I'm really close to my colleagues and they come talk to me. And then you write a book about pain, and I get hundreds of emails a day from people who share their stories with me. But I think for a lot of people, Michael, they still suffer in silence. My mom broke her back while I was writing this book, and she's a very tough woman. But I saw how that hijacked her life, and I also saw how reluctant she was to share her story with people for fear of appearing diminished in their eyes in some way.
Hmm. The last of your resets, which again was something I had no sort of awareness of, we'll call it savoring moments and memory. So I have to say, Sanjay, some of the stuff that I read in your book triggered a memory from Keep Sharp, because I said there's some overlap, although one is on, not to say that they're the same book, they're very different books, but the notion of how do we take care of ourselves, there is some overlap. But savoring was something I hadn't experienced in reading Keep Sharp and was brand new to me, the whole concept of savoring. So can we talk about that a little bit?
I learned about this concept from a guy named Eric Garland, who is at the University of California, San Diego. And it is part of his protocol, which is called the MORE protocol, Mindfulness Oriented Recovery Enhancement. I write about it quite a bit. But for me, what I really took away from, I went and spent a lot of time with him in San Diego. I went through the protocol myself. What I took away from the savoring component, which is part of this MORE protocol, is this idea that in some ways savoring is an active form of gratitude. Like the idea that, hey, look, I'm thankful for something. I'm thankful for this food that I'm about to eat. That is wonderful, and that is a display of gratitude for something. Savoring it is to put every bite in your mouth and truly experience the pleasure of that food. Or to be looking at a sunset and saying, hey, I'm grateful that, I'm seeing this beautiful sunset, is to basically just stare at the sky for a while and really take in every color. It's a really active form of gratitude. And the relevance of it to this book is that because it's part of the protocol, that same protocol that gave you the 5 milligrams of OxyContin value in terms of pain relief, I wanted to write about it. I wanted to explain what savoring was, how to do it, and why it became relevant to the MORE protocol.
Yeah, and it seemed, if I have it correctly, savoring is sort of an immersion in that which you are focused on, the sunset or
Yeah,
whatever. It's an immersion, not
active.
in an active, passive, but an active immersion. Is
That's
that?
right. That's exactly right. It's one thing to be grateful, and that is obviously really important. But to be actively grateful or immersing yourself in the moment in some way. I learned a lot from my own life from this book, and I practice savoring more now. And when I'm with my kids, we'll actively practice savoring. Makes you feel good. There's no question about it. Makes you feel good. And if you want data that it can help with your pain, that data now exists as well.
Yeah. And so you're savoring the past, the present, and the future, right? All aspects of
Yeah,
your life.
and all aspects, but mostly the moment, mostly the present moment is what I think Eric really focuses on.
Yeah.
And you don't have to be there. You can imagine that sunset. You can imagine that beautiful starry night. You can transport yourself back to moments in your life, but you're still in many ways savoring it in this moment, even if it's a recollection of a previous wonderful time in your life.
Yeah, it's very Buddhist in the Ram Dass, be here now, now be here, be active and immersed in the moment.
Yeah.
So, last question for you. Obviously, pain management is evolving. There are new therapies or techniques on the horizon that particularly excite you.
Yeah, I think this new medication, again, the one that I mentioned at the top of the podcast, the first new medication that was approved in 27 years, more than a quarter century. The way that medication works is by blocking certain sodium channels in the body. So the way that the body communicates with itself, sending those pain signals to the spinal cord, to the brain, is all by basically modulating sodium channels. So quick changes in your sodium will send a signal from one place to another, and that all happens in the blink of an eye. What has been challenging, I think, for researchers for a long time is identifying which of those sodium channels are the best to target. And can you target a specific sodium channel without causing some other terrible side effect, for example? With this new medication, it's very interesting is that they found a family of circus performers in Karachi, Pakistan. And these circus performers could do these crazy things to their bodies. They could put sharp objects through their hands and their feet. They could walk on hot coals. They could do these types of things. But what was very interesting about this family was, first of all, it was a family, meaning the whole family can do this. Well, that's interesting. There must be some gene, which there was, called SCN9. But the other thing was that when they walked on hot coals, for example, and you said, I really want to understand what you just experienced here, they would say, "Oh, yeah, I knew that I was walking on coals. I knew that they were hot. I just didn't have pain." That was fascinating because most people who walked on hot coals, they were basically numb to the coals. They felt nothing. They didn't even know they were walking on coals unless they looked down and saw them. So this family was able to specifically inhibit pain without inhibiting other sensation. And so the researchers that saw this recognized it. They found the gene, and basically it took them a quarter century, but they replicated what that gene does in the body into this new medication called suzetrigine. Point being that how we modulate sodium channel blockers going forward, I think, is a really interesting area of science. There may be other, because that drug is non-sedating. It's not working on your brain like opioids do. It's working at the periphery, just trying to block those signals from the injured ankle, wherever you might have injured yourself, from ever getting to the spinal cord and to the brain in the first place. That's exciting stuff. By the way, that's what lidocaine does. Like if I inject lidocaine into your skin before doing an incision, I'm essentially blocking sodium channels in that one area. So that's really effective. But the idea that they could turn that into a pill was pretty remarkable. So that's exciting. I will also say that old existing modalities for pain control are getting a new life. Things like ketamine, for example. Ketamine is thought of as a club drug. It was used as an anesthetic on the battlefield in Vietnam. We know that it can address pain in very different ways, for example, than the way opioids address pain. So even virtual reality, nerve blocks, all these things that we've had in our armamentarium for some time, they're getting a new life, I think, as a result of people wanting to treat pain in different ways.
It's great. I look forward to um, in 3 or 4 or 5 years the update of it doesn't have to hurt as we incorporate all these new modalities or understand more fully the older modalities and this.
There's emergency rooms right now in this country that are basically opioid sparing emergency rooms. It's not that they will never use opioids, but very sparingly, very much a last resort drug. You come in with a broken hip after a car accident, you come in with kidney stones, you come in with migraine headaches, whatever it might be. Like Maimonides Hospital in Brooklyn, one of the biggest emergency rooms in that area. By the way, uh, they have like over 50 languages that are spoken in that emergency room. So they have all these translators that are always walking around the ER. It was fascinating. But they will hardly ever use opioids there. Point being that this transition is already starting to happen. For some people, opioids can be a lifesaver, but these new modalities are proving very, very effective.
It's great stuff. I think when we get off the phone, I'm going to put on my Bob Dylan, Beatles, Joni Mitchell loop and treat my brain to some soothing music.
Suffering relieving music. I love it.
Exactly. Dr. Gupta, it's wonderful to have you back. This is three times now. Keep writing because I love to talk to you. The book is It Doesn't Have to Hurt, your guide to your, I mean, I have to say, the book is It Doesn't Have to Hurt, your smart guide to a pain-free life. Thank you so much for writing this and for talking with me today.
Well, and thank you, Michael, for reading the book and doing all the homework. I've been lucky enough to do a few of these podcasts with you, and I do a lot of podcasts. I really look forward to spending this time with you. So thank you for that.
Thank you very much.